So we are doing osteoporosis in this lecture. So these three things, vitamin D, parathyroid hormone and calcitonin, these three are majorly responsible for the calcium metabolism in our body. So starting with the very basic, bone has two type of cell, osteoblast which makes the bone and osteoclast which breaks or dissolves the bone. So in bone, if there is osteoclastic activity, which means the bone resorption is going on, then the calcium in this bone is going to come over in the blood. So the bone calcium will decrease and blood calcium will increase when there is osteoclastic activity. Done. Now this vitamin D, what it does is it inhibits the calcium excretion, so decrease calcium excretion and increase calcium absorption. So vitamin D increases the calcium in the blood, and this calcium, if it's more in blood, gets deposited and helps in bone formation. So vitamin D is increasing calcium both in blood and bone via decreasing its excretion and increasing its absorption. Done. Now these two hormone, calcitonin and parathyroid hormone, what they does is calcitonin decreases osteoclastic activity. So bone does not get broken enough. So the blood calcium will the, the calcitonin decreases osteoclastic activity. So there is decrease in calcium in the blood. Why? Because bone is not getting resorbed or broken down. So calcitonin increases bone calcium while parathyroid hormone increase osteoclastic activity. So they dissolve the bone and increase calcium in the blood. So parathyroid hormone is hypercalcemic hormone because it increases calcium in the blood, right? And calcitonin decrease calcium in the blood. We are more concerned about calcium in the bone because we are giving treatment to osteoporosis, which has everything to do with the bone, not the blood. Okay. So now the three things that we studied, vitamin D increases calcium in both bone and blood. Calcitonin increases calcium in bone but decreases it in blood, while parathyroid hormone decrease calcium in bone. We are concerned with these two only. So which drugs increase calcium in bone? Vitamin D and calcitonin. So the both of them can be given for the treatment of osteoporosis. Osteoporosis. Done. Because in osteoporosis what we are having is the calcium in the bone is getting out in the blood. So bone is having less calcium. So to increase calcium in the bone we are giving these two drugs in osteoporosis. Okay. So now how many types of drugs we have for osteoporosis? First, which stimulate osteoblast, which makes the bone, which deposit calcium on the bone, so osteoblast stimulators. Or we can inhibit the dissolution of the bone by inhibiting osteoclast, and the drugs which are dual, which can do this and this too. Those are dual drugs. And we have some natural drugs like vitamin D and calcium. Calcium can directly get deposited in bone and treat osteoporosis, right? And vitamin D, as we have studied, increases bone calcium. So first class of drugs we are doing is osteoclast inhibitors. So these are the drugs. Now calcitonin here is taken in intranasal route. This is the drug that you can see. Done. Now calcium dose is 1200 milligram per day. The dietary calcium uptake is around 200 to 300, and the drug intake and the dietary intake combined should be how much? 1200. Done. And the calcium dose is, it was calcium dose, sorry, and the vitamin D dose is 1800 international units. Done. Now we are starting individually osteoclast inhibitors. So before that, you need to get some basics clear. The Paget's disease of bone is related to the calcium metabolism, right? That's the only thing you have to understand here. Paget's disease bone. Done. Now, what are osteoclastic secondaries? See, whenever you have cancer, any cancer, the cancer cells come in the blood circulation and they are roaming all around in the body, right? When the cancer cells reach the bone, these cancer cells release some substances which increase osteoclast activity. So the bone will get resolved, right? So the osteoclastic secondaries are what? These are just the cancer cells which are stimulating the osteoclast. So here you can see there is bone resorption here, bone resorption here. This is caused by what? osteoclastic secondary. So I can say that in malignancy there is increased calcium in blood. How? In malignancy the cancer cells will remove calcium from here, and this calcium will go in blood, so there is increased calcium in blood, right? So with that we are doing bisphosphonates. These are the first class of drugs. So now in bisphosphonates you have to imagine that here we are having a disease called osteoporosis. Why? Because the osteoclasts are very active. So what we are doing is we are taking a drone and we are directly killing this osteoclast. Osteoclasts are bone resorbing cells. So we are killing osteoclasts with the help of this drone. So the drones are drug of choice. Which are the drones? Alendronate, risedronate, and zolendronate. These are what? Bisphosphonates. And these are drug of choice for all kinds of osteoporosis. Whether be it postmenopausal, steroidal induced, any osteoporosis, drug of choice is drones, which are bisphosphonates or dronate, alendronate, risedronate. Any MCQ comes, any osteoporosis, you have to mark this as drug of choice, right? And the mechanism of action is obviously osteoclast inhibition. Now this can also be given for increased calcium in malignancy. I explained you why there is increased calcium in malignancy, right, in the blood. So we are giving these drugs. And drug of choice for Paget's disease of bone. Done. Bisphosphonates. Now calcitonin is the fastest calcium lowering agent from this. Okay. So alendronate and risedronate are oral, and because they are oral, they can cause esophageal toxicity. And zolendronate is IV. Now, osteoporosis is a chronic disease, right? We have to take medicine for like 2, 10, 2, 5, 10 years. Then why are we giving it IV? We can't take an IV for such a long period of time, because when we give zolendronate by IV, it concentrates in the bone for like over 1 year 2 years, so we don't have to give it that frequently. So for chronic disease also we are giving IV zoledronate. Done. Now we are studying this esophageal toxicity. So the oral drugs are causing esophageal toxicity. How exactly? Let's say the drug, even if it touch some part of esophagus, it can cause ulcers. So these are very toxic drugs. So you have to give this advice to the patients before taking this drug. You have to take it empty stomach. Why? Because if your stomach, let's say, is full and the drug is here, then there are chances that it can regurgitate in the esophagus and cause damage, right? So you have to take it empty stomach, not don't take it after meal. Done. Okay, the second one is you have to take it with full glass of water. Why with full glass of water? Let's say you are just taking a drug and you are not drinking water, or you are drinking very little water with it, then what will happen? That the drug will be concentrated here. If you have taken full glass of water, then it will be diluted. So even if there is regurgitation, there is less damage. Done. And now you don't have to lie down for 30 minutes. Now do the drug stay in esophagus for 30 minutes? No, they don't. They stay in stomach for 30 minutes. From stomach it can be regurgitated, so we are not taking any risk. After the drug has passed stomach, then you can lie down, so don't lie down for 30 minutes. Done. And it also causes osteonecrosis of jaw. These are the side effects of oral drugs. Now all the explanation that I've explained are given here, you can revise from it here. Done. Okay. Now what is postmenopausal osteoporosis? In the menopause, we know estrogen decreases. And what's the function of estrogen? Estrogen inhibits osteoclast. So there is no bone breaking or bone resorption. So if estrogen decreases, then there is bone breaking. So that's osteoporosis happening in the postmenopausal age. Now done. So now my question is, can I give bisphosphonates or estrogen in this osteoporosis? See, estrogen is decreasing, then obviously I should give estrogen for this. But estrogen is not the drug of choice for postmenopausal osteoporosis, because I told you any osteoporosis, the drug of choice is what? Bisphosphonates only. Done. So now we are studying some physiological effects of estrogen. What estrogen does in our body? See, estrogen does two good things. The good things are what? It inhibits osteoclast, so there is less bone breaking, and it increases ldl. ldl is the good cholesterol, right? So these are the two good things that estrogen is doing. Estrogen does three bad things. The bad things are: first is breast cancer, second is endometrial cancer, and third is increasing liver clotting factors. So when the clotting factors are increased, there is a risk of this clot formation in the veins, and when there is a clot formation, the blood can't reach in this peripheries, right? So we'll have this type of gangrenes and all, so it's dangerous, right? So this is the bad job of estrogen. These three are the bad jobs. One is breast cancer, endometrial cancer, and the risk of dvt. This is deep venous thrombosis. You'll study more about it in medicine. Done. So now, is it safe to really give this estrogen for osteoporosis when we are having endometrial cancer and breast cancer risk? Obviously not. So what we did was we first combined estrogen with progesterone. Why? Because progesterone decreases endometrial cancer risk, but breast cancer risk breast cancer risk is still there, right? Wait. Yes. So the endometrial cancer risk decreases with progesterone, but still there is breast cancer risk. So estrogen plus progesterone HRTs are not safe for, not good for giving it for osteoporosis. Now that's what is written here. Done. So we are not giving estrogen in osteoporosis, but we can give selective estrogen receptor modulators. Now what are these? These are, let's say I have estrogen is doing 5 works, right? 2 were good and 3 were bad. Now I need a drug which is same like estrogen, but it act as agonist here and antagonist here. Why? Because we want good things, so we want estrogen to act as agonist at receptors in bone and blood, but we want estrogen, or we want the drug we are giving, selective estrogen receptor modulators, to be act as antagonist, so that they don't cause breast cancer and endometrium cancer. So we tried to make this type of drug, but we were not 100% successful. Why? Because the drug that we made was agonist in blood and agonist in bone and antagonist in breast and antagonist in endometrium. We like it, we are not having any cancers, right? But it is agonist in liver also. So in liver it is doing the same thing as estrogen is doing. Estrogen was doing what? Estrogen was doing dvt. So dvt risk is still there, but what has decreased? Breast cancer and endometrial cancer risk has decreased, right? So selective estrogen receptor modulators are obviously better than estrogen. But again my question is, can I give it for a normal person, you and me, normal person having osteoporosis? Can I give it? No, because it is still having dvt risk. So we won't give it in normal people having osteoporosis. We'll give them bisphosphonates only. But to whom we can give it? Let's say a female is having family history of breast cancer, now she is having osteoporosis also. So now I will give selective estrogen receptor modulators. Why? Because it is decreasing the risk of breast cancer also. So this SERM are given in females with breast cancers. Done. Now we have another class of drugs which are monoclonal antibodies against rank ligand. Now what's this? Let's say this is an osteoclast. It has a receptor, rank receptor. There is a ligand which stimulates this receptor and causes bone resorption, osteoclastic activity. Now we need to inhibit this osteoclast because it's breaking the bones, right? So there is an antibody called denosumab which is against this rank receptor. Done. Which inhibits osteoporosis. Now, calcimimetic drugs. Now, what are these calcimimetic drugs? To understand that, first we will have to learn how exactly the parathyroid glands are releasing parathyroid hormone. So, let's say this is the blood vessel and this is a parathyroid gland. So, whenever there is low calcium in the blood, the parathyroid hormone is released in the blood. Why? Because the job of parathyroid hormone is to increase blood calcium. So there is low calcium, parathyroid gland is releasing this parathyroid hormone and it will do its job to increase the blood calcium. Done. So what parathyroid hormone will do, it will go to the bones, it will dissolve the bone, it will stimulate the osteoclast over here, so the bone will get dissolved and there will be increased calcium level in the blood. So when the calcium increase, how will the PTH secretion stop, right? When the calcium increase, this gland has to stop secreting this hormone, right? So how will that happen? Let's say now the calcium in the blood is normal. Why it's normal? Because parathyroid hormone dissolved the bone and increased calcium in the blood, right? So now this normal calcium, when there is increased calcium in the blood, it will stimulate a receptor which is CSAR receptor. CSAR receptor is stimulated by this calcium and this will decrease PTH release. So PTH is not released from the parathyroid gland and there won't be any bone resorption from now on. So now the problem is, what I can do is I can get a drug like calcimimetic drug which can stimulate this receptor and decrease the release of PTH. We don't want PTH in blood because if it will go in blood, it will dissolve the bone and we don't want that in osteoporosis. So we have made calcimimetic drugs which are calcium like drugs because they are stimulating the receptors which was stimulated by calcium. Done. So they are CSCA, calcium stimulating receptor drugs. Done. So this was the normal physiology, and the drugs are cinacalcet and etylacalcet. So here you can just see there is calcium in it. So you can remember the drugs like this. And what they are doing, they are decreasing the PTH secretion. Now all have all that I have explained is written here, so you guys can revise it. So now I am having a disease which is hyperthyroidism induced osteoporosis. What is this? Let's say in the previous image the parathyroid gland was released whenever there is low calcium, right? Their parathyroid gland was released, and when calcium was increased, they will stimulate this receptor, so this PTH should not release in blood. Now this PTH is released in the blood irrespective of the calcium status. If there is increased calcium, even then the PTH is increasing. This is hyperparathyroidism induced osteoporosis, and we all know PTH will dissolve bone and do osteoporosis. So this is hyperparathyroidism induced osteoporosis. What was the problem here? Problem here was that the increase in calcium level was not able to stimulate this receptor to decrease PTH, right? So we are giving directly the drugs which can stimulate this receptor and decrease PTH release. These drugs are calcimimetic drugs. So these drugs are given for hyperparathyroidism induced osteoporosis. Done. Now we have another class of drug. Let's say this is parathyroid hormone. Now what does parathyroid hormone does is, this is a bone. It will remove calcium from bone and increase calcium in blood, right? This is normal parathyroid hormone which is made up of 84 amino acid. It was doing this function. Luckily we found that whenever we cut this parathyroid hormone from here, the first 32 or 34 amino acid of this parathyroid hormone are doing different function. They are taking calcium from blood and increasing calcium in bone, so they are doing the opposite function. So these drugs are called osteoblast stimulators, or wait, I'll explain it fully. So these drugs are called osteoblast stimulators. What these drugs are doing it, let's see. First, the normal parathyroid hormone which is made up of 84 amino acids, PTH 1 to 84, stimulates osteoclast to resolve the bone. But the fraction of parathyroid hormone which is 1 to 34, this will stimulate osteoblast. So osteoblasts are taking blood from blood vessels, sorry, osteoblasts are taking calcium from blood vessels and increasing it in the bone, right? So this PTH 134 is helping us build bones, so we are giving it for the treatment of osteoporosis. So the hormone, so the drugs name are having parathyroid, para represents parathyroid hormone, so we are having the drugs with para in it, so you will remember it like this. Okay, done. So PTH 134, but it's recommended for max to max 10 years, while the bisphosphonates that you are using, you can use it for 10 years. These are responsible, these are recommended only for 2 years, and they are given under the cover of bisphosphonates. You can't give these guys alone, okay? You have to give bisphosphonates with them. and obviously these are peptides, so they can't be taken orally, and the route is subcutaneous. Done. So now we have completed this. Now last one is drug acting by dual mechanism. Dual mechanism is what? Osteoclast inhibition or osteoblast stimulation. For these drugs, you have to imagine this room, and inside this room, two stones are kept. So the room is there, and two stones are kept. Why two? Because we have dual function for these drugs. What are the drugs? First one is strontium renylate. Strontium stones, two stones. Done. Strontium renylate will do, inhibit osteoclast and stimulate osteoblast, and its side effect is thromboembolism. Done. Now there is a protein sclerostin. This protein does the opposite job of what we require. This will stimulate osteoclast and inhibit osteoblast and cause osteoporosis. So we need to stop this drug, right? So for that we have romosumab. This romosumab, go for room romosumab. This will inhibit sclerostin and stop osteoporosis. So we have two drugs for dual mechanisms, right? Done. So now we are summarizing the entire drugs that we studied in this lecture. The first one was natural drugs, simple, directly give calcium that will go to bone and stop osteoporosis, and vitamin D. Done. Osteoclast inhibitors, first was bisphosphonates. They were drawn, see, drawn was there, and drawn was killing osteoclast, which was causing osteoporosis. So the drones are drug of choice, right? Bisphosphonate drones. Then is calcitonin. Third, we studied calcium like drugs, which are calcimimetic drugs, which has CALCIT in their name. Third were estrogen. Third drugs were estrogen like drugs, which were selective estrogen receptor modulators. Fourth was a monoclonal antibody war, which was denosumab. And osteoblast inhibitors were parathyroid analogs, and dual drugs were strontium rentate. So it's just a summary, right? You guys have to read it on your own. And these are calcid drugs, which are calcimimetic drugs. These are having para in it, so these are parathyroid analogs, which are inhibiting osteoblasts. And these are having drones, so there are drones are drug of choice, obviously, and this is for dual drugs. Dual is two stone, strontium rentate, and room is for romosumab. Okay, done. Thank you guys.